Hello, everyone, and welcome to week 7. It is hard to believe that we are almost at the end here. This week, we'll be covering chapters 14 and 15. The items that are due this week include the chapters 14 and 15 in the Smart Book, a Good Sex blog, HPV vaccination blog, Sexual Functions Difficulty Assignment, chapters 14 and 15 quiz, and then, of course, your discussion board. Your final issue paper is due next week, so make sure you are not leaving that to the last minute. So as I mentioned, this week we'll be talking about chapters 14 and 15. And chapters 14 is about sexual function, difficulties, dissatisfaction, enhancement, and therapy. So sex problems are really normal and typical, meaning at some point everyone will experience some type of sexual problem. But there's really been very little research on the sexual function difficulties of those that are gay, lesbian, bisexual, or transgender individuals and couples. Most of the discussion and research for sexual function difficulties really still remain on those that are heterosexual. But in general, heterosexual individuals, gay men, lesbian women, seem to experience similar kinds of sexual function problems. And therefore, the treatment for that is also very similar. And so, looking at defining sexual function difficulties, the standard medical diagnostic system is found in the American Psychological Association DSM number 5, or the 5th edition, using the term sexual dysfunction and sexual disorder. An alternative term, though, has been suggested, and that is sexual function dissatisfaction. And so this is talking about in terms of sexual functioning, but not being happy with how things are going. So looking at it from a more holistic viewpoint where it's maybe not physical, maybe not totally psychological, but really just a general dissatisfaction. With that, we also need to acknowledge the sexual scripts of an individual. So the APA's DSM-5 definition of sexual dysfunction is a clinically significant disturbance in a person's ability to respond sexually or to experience sexual pleasure. All dysfunctions require the symptoms to be present for at least 6 months, unless it's caused by substance or medication use and causes the person significant distress. This manual reflects a psychiatric model. It's presented from a heterosexual context, and it also assumes a linear sequence of a person feeling desire, arousal, orgasm, and so on. So think back to the different phases of the sexual response cycle. The DSM model really reflects that context. And so here's the table of some of the general sexual dysfunctions and disorders, the name, and then also the description. This is also in your text, so I'm not going to read through all the different disorders. Another way to present this is the Working Group for a New View of Women's Sexual Problems in 2001. They offered a different classification system for sexual problems. And they claim that doing a purely physiological framework or looking just at the biology is not the appropriate way to handle sexual problems between men and women. And it really fails to acknowledge the role of relationships and differences amongst women compared to men. And so in this context, they describe sexual function problems as a disconnect or dissatisfaction with any emotional, physical, relational aspect of sexual experience. And so this broadens the identification and the categories to include the sociocultural, political, or economic factors, partner and relationship problems, psychological problems, and also medical factors. And so in a fairly large study amongst Finnish adults, now I just want to caution you when we look at studies of people from Finland, Finland is a very homogeneous population. There's very little diversity in race, ethnicity, religion, and so forth. And so sometimes it's hard to take these studies and apply them to the general to the US because we are such a diverse group of people. But in this study, as you can see here, they found that feelings of sexual desire decreased as the individual aged and as the relationship continued through the years. There is a slight uptick, as you can see, for a woman. I would say around 40 to 49 to 50, and then it goes and then declines again. In a similar presentation, now this is the percentage of, again, Finnish adults who indicated that if they could choose freely, they would like to have intercourse at least twice a week. And as you can see here, so the difference in this table is years in a relationship. So the bottom row is now talking about years in a relationship, or the x-axis, no longer talking about the age. But generally, as the relationship progresses, again, sexual desire declines. Now, inhibited sexual desire is the #1 sexual function problem in American couples. And there's a couple different diagnoses that are related to it. There is female sexual interest or arousal disorder, male hypoactive sexual disorder, and then having erectile disorder. Orgasmic disorders are, female orgasmic disorders are just what it sounds. Females having a difficulty experience orgasm, or when they do experience orgasm, the intensity is reduced. So the idea of a female orgasm is not universal. In men, there are two factors here. There is premature ejaculation, which is, I'm just going to shut this out really quick and open it back up. But premature ejaculation is ejaculating within 1 minute of penetration. And the definition varies among individuals, populations, and cultures because it really has to do with expectations. How long do you want intercourse to last for? Is 5 minutes not enough? Is it too much? So it's very different just depending on expectations. I think the general length of intercourse from penetration to ejaculation is about 3 minutes. And then you have delayed ejaculation. And delayed ejaculation is different in where it is difficult to ejaculate. So either there's a long delay or there's the general inability to ejaculate. Then there's sexual pain disorders, and these are exactly what it sounds like when a person experiences pain in any of the phases of the sexual response cycle. And the main is the genetic pelvic pain penetration disorder. There's 4 different categories for this, but it is diagnosed by having marked difficulty having vaginal intercourse or penetration, marked vaginal or pelvic pain during intercourse or penetration attempt, an intense fear or anxiety about vaginal or pelvic pain in anticipation of vaginal penetration, and then just a tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. Now, these all show up in the DSM-5. The other category, which is andodyspareunia, which is the same symptoms except during anal intercourse. Now, that one does not show up in the DSM-5. So what are the causes of these? So in the past, the researchers really felt the problems associated with it was purely psychological. So it had to do with stress management, learning how to calm down, not tense up, and those things. But current research suggests some other factors, and these include subtle influences of hormones, having vascular, neurological, and endocrine system, and various related illnesses and disturbances, some certain prescription drugs, and then also some of the treatments for cancer can impact or can influence pain felt during intercourse. In terms of men, some of the physical causes in men are diabetes and alcoholism. Those are the main causes of erectile difficulties. But other causes include lumbar disc disease, multiple sclerosis, atherosclerosis, spinal injuries, prostate cancer, drug use, smoking, bicycle-induced sexual difficulties, and then diseases of the heart and circulatory system. Amongst females, or once women, it's it's really similar to men. So you have diabetes and heart disease, hormone deficiencies and neurological disorders, general poor health, fatigue, drug use, alcoholism, spinal cord injuries or multiple sclerosis, having obstructed or thickened hymen, clitoral adhesions, infections, scars, constrictive clitoral hood, vulvodynia, or weak pubococcysis, which is the pelvic floor muscle. In addition, there's antihistamines in marijuana can also cause some problems in women as it relates to sex. Endometriosis, which is the growth of the uterine lining outside the uterus, ovarian uterine tumors and cysts, and then clitoral irritation or vaginal or urinary tract infections. There's a multiple causes for sexual dysfunctions in women. When we look at the psychological causes, some of the immediate cause include fatigue and stress, ineffective sexual behavior, sexual anxieties. This is evidenced by a phenomenon called spectatoring, in which a person feels as if they're the spectator of their own sexual behavior. And then just having this excessive need to please a partner. And while doing so, not that that's a bad thing, but while doing so, they stop feeling pleasure themselves. Also, some other additional psychological causes can be various conflicts with the self. For example, amongst gay men, lesbian women, and bisexual individuals, there's something called internalized homophobia. And this is the self-hatred of one's own homosexuality. And so for people who have internalized homophobia, it's difficult, it may be difficult for them to engage in sexual behavior at the same gender because they just keep having this negative self-talk in their head. In addition, other sources of severe difficulties can include having an experience with childhood sexual abuse, adult sexual assault, or rape. There are also relationship causes. It doesn't necessarily have to be as trauma, right? At any point in time, all couples will eventually experience some difficulty. And so maybe during those times of difficulty, there was not a lot of sexual arousal or attraction. But the challenge when thinking through these difficulties is just balancing how to be separate, how to be together, how to maintain your own individuality while being part of a couple. And then sexual function enhancement. So this refers to improving the quality of the sexual relationship. So it's enhancing the sexual part of the relationship. Generally, these programs aim to first educate about sexuality, as I'm not sure many people truly know how their sexual side works. Develop communication skills. Generally, the number one reason couples have sexual issues is lack of communication. Foster positive attitudes for sex, and then provide sexual homework for practicing techniques discussed in therapy. And then lastly, increase sexual awareness. And so this is part of one of your assignments this week is what is good sex? So we've been talking about sexual therapy or sexual function dissatisfaction, but what would satisfaction look like? Is it obtaining orgasm? Is it having sex for 5 minutes? Is it a lot of foreplay? So in this week's assignment, I asked that question, what does good sex mean to you? Because what it means to one person may be very different to what it means to someone else. But generally, all people should feel good before, during, and after engaging in sex. And then to fully enjoy sexuality, you need to explore what are your conditions for good sex. As each person is different, we're individual, so the conditions for good sex is going to vary. And then developing self-awareness is important when increasing sexual satisfaction. So typical homework exercises that will be assigned is mirror examination, particularly for women who may not be that familiar with their own body and especially genitalia. So to grab a mirror and inspect oneself, see what you're made of, where all the parts are, where the vulva is, where the vaginal opening is, the clitoris, the clitoral hood, just to get an awareness of your own body. And then more often than not, there'll be this body relaxation exercise and exploration. So learning what feels good for oneself, and that will include masturbation. Because the truth is, if a person doesn't know what provides them pleasure, then it's very difficult to tell a partner how to please them. Developing your own erotic sexual voice. Now, I don't mean talking out loud, or it certainly can include that. But what feels good? How are you going to explain what feels good to someone else? How are you going to encourage continuing a behavior? How are you going to encourage stopping something that doesn't feel good? And then for both men and women, there are Kegel exercises, so tightening or the strengthening of the pelvic floor muscles. And then lastly, there are erotic aids and sex toys, and these are products designed to enhance erotic responsiveness. And if couples are open to using them, they can be very effective. Or if a person's open to using them on their own, again, they could be very effective. And then intensifying erotic pleasure. So developing and maintaining sexual desire is important to satisfy a couple sexual style. And the key is to integrate this idea of intimacy, so connectedness to eroticism by building bridges to desire. And increasing sexual arousal really has two elements: having your conditions for good sex met. And again, for that, you need to define what good sex means to you. And then focusing on the sensations you are experiencing. So learning to appreciate those sensations, and allowing yourself to feel pleasure. And ultimately, this idea that sexual passion and satisfaction needs to decline as you age is not a foregone conclusion. You don't need to have a decline in sexual passion and then satisfaction as you get older. All right, so treating sexual function difficulty. So Masters and Johnson were really kind of the first pioneers in creating this cognitive behavioral approach. And they state that the majority of sexual problems are the result of sexual ignorance, faulty techniques, or relationship problems. And so they create the treatment using a combination of cognitive and behavioral techniques. They also work on treating couples, not the individuals. And one of their pioneer treatments is sensate focus. And in this, you practice touch and giving and receiving pleasure to your partner. Other sex therapy utilizes different techniques for treatment specific problems. So these are more matched to what the problem is. So, for example, for female orgasmic disorders, partners are encouraged to support the woman to have an orgasm any way it happens. And so, generally, for most women, they do not experience orgasm through penetration, and it does involve some sort of clitoral stimulation. And so, in this, the partners together would work on that, and wait until the female achieves an orgasm. And it's practicing patience. It might not happen right away, it might not happen the first time, but being patient, um, which, would help reduce anxiety too. For erection difficulties, sometimes just removing the fears and anxieties is the first step in therapy. And so, what I mean by this is that sometimes in men who have erection difficulties, it happens once or twice, and then they start worrying about it. So every time they engage in foreplay or in some sort of sexual activity, they start worrying, oh my God, what if I don't have an erection? What if it doesn't happen again? That's going to really be embarrassing. This is going to suck. And that thought process leads to then having erectile difficulties. And so in this, it's removing that negative self-talk, that anxiety is the first step. And then early ejaculation, there are therapies that include something called squeeze technique. And so in this, there is penetration. And then as the man gets closer to orgasm, he would stop and squeeze the base of the penis to end the sensation, wait until they calm down a little bit, until the excitement reduces, and then continue on with penetration. And then the last is delayed ejaculation, where the man is coached to focus on the sensation. So not focus on when ejaculation is going to occur. Is it going to occur quick enough? It's to sort of slow down and be mindful and present in the moment to just experience the sensation of penetration. And there's also some common erection myths. So this list here are myths. These are not true statements. So erection is something that has to be achieved. Men are sex machines. They are always ready, always hard. During a sexual encounter, you only get one shot and an erection. I blew it last time, I'll never get it up again. If I can't have an erection, my partner can't be sexually satisfied. So these are all myths, right? They're not true statements. Helen Singer Kaplan identified a approach by modifying Masters and Johnson's behavioral treatments to also include psychosexual therapy. Other non-medical approaches tend to work around the expense in time and money of cognitive behavioral and psychosexual therapy. There's also the implicit model of therapy, and this stands for permission, limited information, specific suggestions, and intensive. And there are also multiple self-help groups and group therapy. But because sexual functions are often a combination of physical and psychological problems, there are also medical approaches. There's lubricating jelly or estrogen therapy for vaginal pain. What this does is increase lubrication, so there's not that tightening, that friction that often causes pain. There's testosterone therapy for loss of drive and function. There's low energy and strength, and also helps with depressed mood and low self-esteem. There is microsurgeries to help improve a blood flow problem. There's medication for the men to help achieve an erection. That's Viagra, Levitra, Cialis. There's ADI, which is a medication to boost a woman's sexual desire. And then there's also homeopathic products. So this brings us to the next chapter, which is sexually transmitted infections, so STIs. Sexually transmitted infections refer to more than 25 different infectious organisms that are passed from person to person, primarily through sexual contact. You'll often see two numbers associated with this. There's incidence, which is the number of new cases, and then there's prevalence, which is the number of total cases. So prevalence is the number of new cases, but also existing cases. So it has been considered an STI epidemic. So infection with an STI organism can take place with or without developing an illness or disease associated with that organism. So you could have an infection, not have any symptoms, and have it not progress to any disease or illness. And so for this, and because of socio-cultural taboos, STIs have been considered the hidden epidemic that make them a particular threat to the public health. And there are two general types of STIs. There's bacterial and curable, and it's just what, right? They're a bacteria and they can be cured. These are examples are chlamydia and gonorrhea. But there's also viral and incurable. But thankfully, these are treatable. So you'll always have it, but the symptoms may be reduced. And examples of this are HIV infection and genital herpes. So STIs are often silent. So this means that they go undiagnosed because maybe there's no early symptoms, or the symptoms are ignored and untreated because of embarrassment, shame. But a few STIs are reported into a system, and I don't mean reported with your name attached, but just reported to the government, or the government CDC can get numbers. Gonorrhea, syphilis, chlamydia, hepatitis A and B, HIV/AIDS, and chancroid. So who is affected by STDs? There are gender disparities, and this is also known as biological sexism because women are more at risk for STIs because of how our bodies are designed. So women, the vagina is an internal organ, it's a mucous membrane. When women are engaging in penetration sex with men with a penis, the penis ejaculates into the vagina. So there's no skin, there's no barrier to protect the woman from obtaining an infection. So therefore, because our women's organs are internal, they're more at risk. And men who have sex with men are also at risk because the penetration occurs in the anus. And again, that's an internal organ, so that there's no barrier to prevent an STI from entering the body. There's also age disparity. So compared to older adults, sexually active adolescents and young adults are at higher risk for acquiring an STI. And there's also race and ethnicity in the US that are STI risk markers that correlates with other determinants of the health status. So, factors that contribute to the spread of STI, these are behavioral factors. So, having sex at an early age, having sequential sexual relationships. So, having multiple sex partners one at a time. So, it's called serial monogamy. You have a relationship, you have sex, you break up, you go to someone else. Relationship, sex, break up, someone else. Having concurrent sexual relationships or overlapping partnerships. So, you're having multiple sexual partners. Um, having high risk sexual partners, having high risk sexual behaviors. So, high risk of sexual behaviors would be penetrative sex, inconsistent and or incorrect condom use, substance abuse, sexual coercion, lack of knowledge or lack of a concern about getting an STI, and having an erroneous perception of a partner's STI status. So, just thinking your partner doesn't look like they have an STI, so they don't. Other risk factors include poverty and marginalization, where it puts people into groups, which high risk behavior is common. And then also that is associated with limited access to healthcare. Access to high quality and culturally sensitive healthcare is really imperative for early detection, treatment, and prevention. Again, there's this idea of secrecy and shame and moral conflict about sexuality. And so that leads to people preventing people to go seek help when there is a problem with their genitals. There's also a cultural stigma associated with STIs, having a general discomfort to sexuality issues. And as most STIs are asymptomatic or symptoms are mild, people don't seek help or don't seek care because their symptoms are very mild or there are no symptoms. And so the consequences of STIs can be pretty damaging, and particularly for women. So women and infants suffer more serious health damage than men from all STIs. If left untreated, STIs can lead to blindness, cancer, heart disease, infertility, ectopic pregnancies, miscarriage, and death. People with STIs are also more at risk for getting HIV. And the direct cost within the US healthcare system is about $16 billion every year. So the next three charts are just tables of the different STIs, their symptoms, time from occurrence of symptoms, medical treatments, and then just some additional comments. So these are also in your textbook. I'm not going to go through all of these or really any of these. I just want to direct your attention to make sure you check these out to get familiar with the different STIs that are out there. So the principal bacterial STIs are chlamydia, gonorrhea, and urethritis. Chlamydia is the most common STI and the most commonly reported infectious disease. Gonorrhea is the second most commonly reported notifiable disease in the US. Then there's urinary tract infections, which include urethritis. It's an inflammation of the urethra, and it can result from sexual exposure and non-infectious conditions. It's also known as non-gonococcal urethritis, or NGU. And all of these are treatable. And one of the ways to prevent the urinary tract infections and this is for women primarily, if you are engaged in a heterosexual relationship and you are having sex, then you can make sure you urinate right after intercourse, or make sure your partner uses a condom. Because what happens is after intercourse, bacteria just from the semen from the environment can get into the urethra, which causes that infection. All right, syphilis is caused by a bacteria. It's often called the great pretender because the early signs and symptoms are indistinguishable from those of other diseases. And it progresses through three discrete stages. There's the primary infection, the secondary, and latent. And it's successfully treated with antibiotics in both the primary and secondary stage, and can also be treated with antibiotics early in the latent stages. And then principal viral STI. So these are ones that are caused by a virus. Again, these are not curable, but they are treatable. We have HIV and AIDS, which is an enormous public health challenge nationally, more so globally, claiming millions of lives, although now it's treatable. And I believe that currently with treatment, the life expectancy of a person who is HIV positive is almost the same as someone who is not. AIDS stands for acquired immunodeficiency syndrome, whereas HIV is the human immunodeficiency virus, which causes AIDS. Genital herpes is caused by the herpes simplex virus, type 1 and type 2. It's common in the United States. It's found and released from the source that the virus causes. Between outbreaks, though, it still can be released from the skin that doesn't appear to have a sore or be broken or cut or anything like that. And so it is now assumed that the person is still virus shedding, even if you can't see any symptoms of having it. There's no cure, but there are medications that can help keep the virus in check. Human papillomavirus infection, or genital HPV, is a group of viruses with more than 100 different strains. But the most common STI among young adults, sexual active people, particularly women. Certain types of HPV can cause genital warts in both men and women. Other types have been associated with the cause of cervical cancer. And then less common though, but still present, are cancers of the vulva, vagina, anus, and penis. There are HPV vaccinations available to protect from obtaining an HPV infection. Hepatitis is an infection that produces an inflammation of the liver, and the two most common types are A and B, but C is also present. So hepatitis A is primarily through oral contact with food or water contaminated with fecal matter. Hepatitis B, which is highly infectious, is spread through sexual contact in blood, semen, saliva, vaginal secretions, and urine, and can also be prevented by a vaccine. And hepatitis C is primarily through contact with infected blood, and this also is more likely to develop into a chronic infection. Then we have Zika, the Zika disease, which is caused by the Zika virus. This is spread to people primarily by mosquitoes, but infection during pregnancy can cause serious birth defects called microencephaly and other brain defects with the infant. It can also be transmitted through sexual activity with an infected person. So here's an example of an STI that more likely is transmitted by a mosquito, but can be passed through sexual activity. And then for vaginal infections, we have bacterial vaginosis, which can be caused from different organisms. Most commonly, it's the Gardnerella vaginitis, which is a normal inhabitant of a healthy vagina, so it's normally there, but when it starts growing out of control, it can result in vaginal discharge, odor, pain, itching, or burning. Usually it can clear up without treatment, but antibodies are often recommended just to prevent infection of the uterus and fallopian tubes and maybe reduce the risk for some other STIs. One of the more common infections of the vagina is the genital candidiasis, which is a yeast infection. And this is a common fungal infection. It occurs when there's an overgrowth of the fungus. Now, candida is already in the body. So having it in the body does not suggest something is wrong. But it's when it starts growing out of control that it becomes a problem for women. So it's rare in men. Nearly 75% of all women have had at least one case in their lifetime. It can be promoted by use of birth control pills, antibiotics, frequent douching, pregnancy, and diabetes. It's less commonly transmitted through sexual intercourse, and it's just treated with antifungal over-the-counter medication. Trichomoniasis is an STI that's caused by a single-cell protozoan. It's a parasite. It's the most commonly curable STI. It's more common in women compared to men. And it's sexually transmitted during either penile vaginal intercourse or vulva to vulva contact. Prescription drugs are effective in treating it. And then to prevent reinfection, both partners must be treated. Ectoparasitic infections, so these are parasites. We have scabies, which is a red itchy rash caused by a barely visible mite. It appears on the genitals, buttocks, feet, wrists, elbows, knuckles, abdomen, armpits, shoulder blades, or scalp. And it's treated with a prescribed lotion. And then there's pubic lice, which is commonly known as crabs, but it can move from the hair of one person to the next person. I'm sure you've heard of head lice, same idea, except this is usually found in the genital area, the pubic hair, and can be transmitted through sexual contact. And again, for this, you can use both either over-the-counter treatments, or there's also prescriptions that are available. Pelvic inflammatory disease. So women are particularly vulnerable to this. And this is a complication to an untreated STI. But there are serious ramifications to having PID. So it occurs when the bacteria from the vagina or cervix moves into the uterus, into the fallopian tubes, and other reproductive organs. It's one of the leading causes of female infertility. And 1/3 to 1/2 of cases are associated with having untreated gonorrhea and chlamydia. But the symptoms vary from having no symptoms to subtle symptoms to mild symptoms to very severe symptoms. And then cystitis is a bladder infection that affects mainly women and is often related to sexual activity. So it's not really transmitted from one partner to another. It's characterized by a painful burning urination and a nearly constant need to urinate. But it occurs when a bacteria is present in the body and it's introduced to the urinary tract. Delayed treatment can result in damage to the kidneys as the infection then travels up to the kidneys. So how to prevent STI? So obviously practice abstinence. If you don't have sex, you can't get an STI. You can practice sexual exclusivity, meaning you and your partner agree to be sexually active only with each other. You reduce your risk during sexual intimacy. Select your partners carefully. Avoid having numerous partners. Avoid injection and other drugs. Get tested, get vaccinated, protect the babies, and be a good communicator. Other ideas are practicing health promoting behaviors, such as always using condoms, recognizing STI symptoms early, and then seeking treatment or a diagnosis early, and encouraging your partner also to get tested, diagnosed, and treated. This concludes our presentation for this week. Have a wonderful week.